In this excerpt from the IAOMT's Word of Mouth podcast, Dr. Jerry Bucco talks with Dr. Stuart Nunley about some of the treatment methods for lesions in the mandible. After the video, we'll discuss some of these methods as well as others in more detail.
What other bones in the body are prone to have osteonecrosis other than the jaws and the hip?
The hip is very susceptible because it has a blood vessel going in to the end of it, or near the end, and it gets kind of crimped off when you put a lot of weight down in a certain way. The knees, I think just because of all the weight that they have to hold up, are susceptible, and the lower spine is susceptible. This is a funny disease because until the 70s or 80s, there were lots of papers in the orthopedic literature, but it was under 72 different diagnostic names because all the papers were written by surgeons, and mostly in Europe. And the tradition there was, if Dr. So-and-so was the first to write about a disease, then we call it Dr. So-and-so's disease. And so we had, out of those 72 names, about 50 of them were some doctor's name. And then I came along, and a couple of medical pathologists came along about the same time and looked at the tissue and said, hey, this is all the same disease. So every bone is susceptible, even the small bones of the fingers. But now we know it's all just one disease.
In recent times, a number of adjunctive therapies have been proposed in terms of treating these lesions in the mandible. We know that we can surgically go in and treat these areas, or the maxilla. But other things have been proposed as well, ozone being one of those. Can you list some of those other adjunctive treatments?
Well, the ones I know about ozone because a bunch of my biopsy service contributors, many who have become lifelong friends, they have used it and they claim to have great success. I don't know of any study using ozones, and that's got to be done sooner or later. I had heard of people using low-level laser therapy, and I was asked to do a research project by somebody who used those low-level lasers, and he had developed an array of LED lights so that the patient could just sit at home and watch TV while the LED light at the right wavelength went right through the alveolar bone. And I told him, he was from Canada, and I told him on the phone, I don't know anything about this kind of therapy. It's kind of like voodoo. And he said, would you read some papers if I sent them to you? And so he sent me about 80 Xerox copies of articles. And that got me interested. And there's just so much research, especially coming out of the veterinarian field, because they've been using this since the 1960s. And there's a lot of science behind it. If you send the light at the right frequency through bone, it stimulates new bone formation, new bone cells. It opens up blood vessels, gets more blood flowing through it. Any inflammatory cells in the area, they become more successful, I guess you could say, activated. It does a lot of good things for the healing process, and that is something specifically that's been looked at in some bones, not necessarily the jaw, but if you hit it with this low-level light therapy, then it will move an inflammatory process on into the healing phase. And so it must be stimulating fibroblasts and other aspects as well. So that's something that I finally became familiar with, and he said, you willing to do that project now? And so I said, okay. And he treated the patients. These were sites where teeth had been gone for a long time. They were going to put an implant in. And we used quantitative ultrasound, which is designed to find essentially ischemic bone rather than inflammatory bone. And we did the quantitative ultrasound tests in the area they were going to do the implant in. And then we used his array of LED lights and just hung them off of a pair of glasses right over wherever the site was. And we just kind of made up numbers. We told the patients, use it for 20 minutes for 4 weeks. And in the laser therapy business, you take a break every once in a while. So we told them not to use it on weekends. So we were flying by the seat of our pants, but the results came out pretty dramatic. We found maybe a third of these sites were, in fact, either low bone density or dry bone or hollow bone. And that was from quantitative ultrasound. We didn't do any biopsies. But then we did the ultrasound after that treatment, and we had to grade the ultrasound on a 4-point scale. We had to make up a scale. There was a lot of, I felt like the Wright brothers, starting from scratch. But we had a lot of high-grade lesions that went to very low grade or even zero, just using that very painless type of therapy. So I think it's because of increased blood flow more than anything else. And Boyd Haley, with the material that he's been researching, he mentioned today he thinks increased blood flow is the key. So there have been other people. I've had some people who would inject colloidal silver, but I've had also a couple of patients, not my patients, but a couple of docs call me saying, I put that colloidal silver in and the pain went skyrocketing and it was much worse than before. I've had people open them up and put the platelet-rich materials in there. It could be just all by itself, the blood products, or it could be mixed in with a bone, artificial bone, either human or cow bone. Sure. And they claim that is much better. I also have a fellow who is using electromagnetic waves. There's a Beamer company in Germany that makes a strap that you could just lay over your face, and he said that has helped get rid of the pain all by itself.
So as you have heard, surgical curettage is one treatment method used for NICO. The success of surgical curettage of painful lesions seems to follow the old adage that where there is more bleeding provoked, bone will follow. Repeated procedures were required to reach the final result in many cases. Surgical curettage remains the standard for definitive treatment. Anticoagulation, or use of medicines that help prevent blood clots, is another treatment method used for NICO. This is because some rate of relief of pain in long bones and jawbone neuralgias has been achieved with anticoagulation therapy, counteracting the effects of the patient's endogenous hypercoagulation tendencies. It can provide relief in up to 40% of NICO cases, especially surgical failures. For more information, see these sources. Gluck, C.J. et al., Thrombophilia, Hybrofibrinolysis, and alveolar osteonecrosis of the jaws, oral surgery, oral medicine, oral pathology, oral radiology, and endodontology, 1996. Grupo R et al., The Pathophysiology of Alveolar Osteonecrosis of the Jaw, Anticardiolipin, Antibodies, Thrombophilia, and Hypofibrinolysis, Journal of Laboratory and Clinical Medicine, 1996. Another treatment method for NICO is ozone therapy. Oxygen ozone gas is injected into a dose-controlled manner into identified lesions and can be a profound disinfectant. Many of the anaerobic waste products of microbial metabolism are themselves prothrombotic and tend to perpetuate the ischemic problem. Ozone can also provide a number of healing mechanisms that result in the generation of new circulation. Authors of 2013 research entitled, quote, A Review of the Properties and Applications of Ozone in Endodontics, an Update, end quote, documented a series of studies on the topic and concluded, quote, ozone improves wound healing, assists in treating root caries, and can be used against endodontic microbiota, end quote. The source is Mohammadi Z et al., A Review of the Properties and Applications of Ozone in Endodontics, an Update, Iranian Endodontic Journal, 2013. Low-level lasers and near-infrared LED devices are used to promote bone healing and regeneration of circulation over a period of months. In research titled, quote, Application of Photodynamic Therapy in the Treatment of Osteonecrosis of the Jaw, end quote, and published in 2020, the authors reported, quote, besides the conventional surgical treatment, photodynamic therapy can be a viable supportive tool of initial and advanced stages of osteonecrosis and may contribute to improvements of patients' quality of life, end quote. The source for this is Vuletic M. et al., Application of Photodynamic Therapy in the Treatment of Osteonecrosis of the Jaw in Photodynamic Therapy from Basic Science to Clinical Research, 2020. There are other NICO treatment methods being explored as well. For example, shockwave therapy is based on the principles of ultrasonic lithotripsy and success in treating orthopedic neuralgias. Inducing microtrauma by treatment of ischemic jawbones with an extraoral ultrasonic wand can induce new circulation and bone regrowth. As another example, platelet-rich fibrin is another NICO treatment method. The use of platelet-rich fibrin concentrates in surgical procedures is not only beneficial from a clotting standpoint, but also from the aspect of releasing growth factors over a period of up to 14 days following surgery. Is there such a thing as a simple extraction? It appears that some undetermined percentage of the population will experience ischemic bone healing of routine dental extractions due to their underlying hypercoagulation states, but dentists don't test for them before proceeding, nor do we take into account the load of infection and trauma the site has accumulated. We just assume they'll heal. Here are some strategies that biological dentists have come up with in an effort to mitigate these risks. Number 1, minimize the use of vasoconstrictors, even for surgery. This avoids the transient ischemia that can be so damaging to osteocyte viability. Number 2, curette the socket with the burr to remove remnants of the periodontal ligament. The ligament is a barrier that normally prevents the root surface from getting involved with the bone replacement cycle, so it may block the bone remodeling system from fully accessing the socket. Number 3, perforate or decorticate the lamina dura with a burr. This gives the marrow cells, macrophages, and stem cells better access to the organizing blood clot in the socket. It follows the concept that micro-injuries to bone stimulate better healing too. Seeley T.C. et al., Bone Adaptation to Load, Microdamage as a Stimulus for Bone Remodeling, Journal of Anatomy, 2002. Number 4, irrigate the extraction site copiously as you are curating and burring. Use lots of saline, ozone-saturated water or saline, or other disinfecting solution. Try to reduce the local burden of infection. Number 5, employ good socket grafting to reduce dry sockets. Especially in favor now is the use of autogenous platelet-rich fibrin dressings.